I'll explain why I am very pleased in a minute, to introduce today's speaker, who is Aishah Scott. Aishah, let me read her little bio, and then I will give a little informal bio because I've known Aishah a very long time. So Aishah Scott is an expert in public health and African-American history at Providence College. She's working on a book manuscript entitled Respectability Can't Save You, the AIDS Epidemic in Black America. This work explores the impact of HIV/AIDS in the African-American community and the role of, quote, respectability politics on state and community leaders from 1980 to 2010. She addresses how several forces shaped the national, local, and community responses to the epidemic. Now, if this isn't a timely dissertation, I don't know what is. She is an advocate for social justice and closing gaps in healthcare for underrepresented communities. Now, here's the unofficial part. Aishah was an undergraduate and a graduate student at Stony Brook, my university. She was an undergraduate political science major, but then she saw the light and became a graduate student in the history department, which is my department. In, I think, her first year in graduate school, doesn't really matter, she took a graduate seminar co-taught by me and by someone in our department who was a specialist in medieval history. And in spite of that, she decided not to go into Russian history or medieval European history. She stayed in the area that she had already chosen. And, you know, she has just, I don't want to say blossomed, that sounds too paternal, but she has really made a career for herself, written a wonderful dissertation, and is in the beginning of a wonderful career at Providence College. So Aishah's talk today is entitled Public Health and Systemic Racial Disparities. So Aishah, please, the floor is yours. Everybody else, remember to mute yourself.
Thank you so much for the warm welcome, Gary, for both the official and unofficial introduction. He's correct, I'm a lifetime Seawolf, even though I'm now at Providence College. So thank you so much for that. So good afternoon, everyone, and thank you so much for taking the time to join this conversation today about public health and systemic racial disparities. More specifically, I will be discussing critical race theory, respectability politics, the HIV/AIDS epidemic in Black America, and its implications on racial health disparities regarding the COVID-19 pandemic. Critical race theory holds that race is a social construction without a biological or genetic reality that society invents, manipulates, or retires when convenient. My work employs critical race theory to explore respectability politics or moral policing from a top-down perspective in the AIDS epidemic, with elites and the state, excuse me, wielding respectability against marginalized communities. I'm so sorry I started with this and I didn't even share my screen with you all. I'm looking at the presentation and you all can't see it. Hold on.
We're looking at you. Okay.
All right. Okay, so just before I dive in, I just want to give a brief overview of the state of the AIDS epidemic in Black America. So in 2017, African Americans, who accounted for only 13% of the US population, still accounted for 43% of the new HIV diagnosis. African Americans have accounted for nearly half of new infections since the mid-1990s. When people think about the HIV/AIDS epidemic and the browning of the epidemic, they typically think of this as something that onset in the 90s, but African Americans were always disproportionately impacted by HIV/AIDS. In fact, by the late 1980s, they already accounted for 1 in 4 persons living with AIDS. And of course, after the redefinition of how how AIDS is classified in 1993, we saw a huge influx to accounting for over a third of persons living with AIDS, and African Americans have hovered at about nearly half of new infections since the mid 1990s. So when a devastating epidemic, sexually transmitted, deadly, but initially associated with gay, mostly white men, began to spread disproportionately among African Americans in the late 20th century, many state and Black community leaders avoided acknowledging the scourge in their midst for as long as possible. The reticence on the part of that leadership, both at the community and state level, not only exacerbated the spread of medical misinformation, but also shaped the public health policies toward the epidemic. Similarly, the current COVID-19 pandemic has also been plagued by reticent responses from state leaders that led to deadly misinformation and disproportionate loss of life among African Americans. Quote, incidence, hospitalization rates, and mortality were highest among Black African American and Hispanic Latino persons, as well as those who were living in neighborhoods with high poverty. This is a quote from a COVID-19 Centers for Disease Control report. But strikingly similar language can be found in HIV/AIDS CDC reports from the late 1980s to 2018. In 2018, African Americans and Latinx persons respectively accounted for approximately 42% and 27% of new HIV infections, combining for 69% of new infections. As of early March, Black people were the most likely to die from COVID-19, accounting for 15% of deaths in the United States. As Gary mentioned, I'm currently working on my book manuscript called Respectability Can't Save You, the AIDS Epidemic in Urban Black America, which focuses on the impacts of the HIV/AIDS epidemic in the African American community and the role of respectability politics or moral policing on its leadership during this period. In particular, my work addresses several forces and how they shaped the national, local, and community responses, or lack thereof, toward the African American HIV/AIDS epidemic, especially in New York City. My research uses New York City as a case study because it has historically been one of the most impacted regions by HIV/AIDS since the inception of the epidemic in the early 1980s in the United States. Additionally, New York City was often at the forefront of policy change to increase access to care for those living with the disease. These forces include the influence of the Black church, the impact of respectability politics from federal and local government, class dynamics, and gender relations. These forces have also played pivotal roles in responses to the COVID-19 pandemic and its impact on Black and Latinx communities that I will discuss today. Unfortunately, New York City was also an early epicenter of the COVID-19 pandemic, making it a very suitable point of comparison of responses to the two public health crises. Today, I will explore how the HIV/AIDS epidemic in the African American community and the incredible parallels to the current COVID-19 pandemic due to their shared root causes in terms of systemic socioeconomic disparities. In excavating how the aforementioned forces profoundly shaped responses to HIV/AIDS among African Americans, I tell the story of a community silently ravaged by the epidemic. Unraveling these forces also illuminated how white supremacy pushed back on the legislative successes of the civil rights movement through racially coded policy reform to preserve its autonomy. Through an exploration of HIV/AIDS, I argue that the history of African American public health has largely been shaped by the imposition of and resistance to respectability politics of the state. HIV/AIDS is a vehicle, a placeholder of sorts, for understanding the ways in which respectability politics have been used to systemically racialize socioeconomic disparities that inherently leave the African American community vulnerable. A vulnerability that is being highlighted again today with the COVID-19 pandemic. I argue that this vulnerability, by intentional avoidance of systemic root causes, including access to affordable housing, employment, quality education, and healthcare, is purposeful and historical, justified through racialized manipulations of respectability. Refusal to treat poverty as a trigger for the HIV/AIDS epidemic in the African American community is a contemporary manifestation of medical racism at best and genocide at worst. The impact of this willful avoidance is clearly evidenced in the current COVID-19 pandemic, where the CDC literally cited access to affordable housing, employment, income gaps, and quality health care and education as the foremost reasons for disproportionate COVID infections and deaths in Black and Latinx communities. Building on the work of scholars of African American public health like Alondra Nelson and Samuel Roberts, my research uses HIV/AIDS as a case study to make three important historiographical interventions that have larger implications for our understanding of respectability politics in African American public health. First, by applying critical race theory, it reveals how respectability politics impacted health outcomes by influencing the decisions of leaders both inside and outside of the African American community. Second, it reconsiders the long-term impact of the civil rights movement by examining how white supremacy prevented the legislative successes of the 1960s from achieving full racial equality, a failure which left African Americans perpetually vulnerable to health disparities. Third, it not only expands, but reconfigures the definition of respectability politics. Typically, the term has been defined as a problematic tool of resistance that is passively complicit with white supremacy. But this work examines respectability politics as an active weapon of oppression. Additionally, my work draws on emerging carceral state literature to highlight the many intersections between mass incarceration and public health policy toward the African American HIV/AIDS epidemic. The American public health community has long recognized the connections between systemic poverty and disproportionate HIV/AIDS infection rates in disenfranchised communities. The Centers for Disease Control asserts that African Americans experience disproportionate poverty and the socioeconomic issues associated with poverty, including limited access to high quality healthcare, housing, and HIV prevention education, directly and indirectly increase their risk for HIV infection. While this work supports the recognition of disproportionate poverty in African American communities and its overlap with disproportionate infection rates, that is not its purpose. Rather, this work explores how the systemic socioeconomic disparities in the African American community are intentional through manipulations of respectability politics for the maintenance of white supremacy, subsequently leaving the community vulnerable to health disparity. The reasons I employed New York City as my case study for local government and community responses to the epidemic in the African American communities are numerous. First, New York City has been and continues to be disproportionately impacted by HIV/AIDS, both generally and among marginalized populations since its onset in the early 1980s. Subsequently, New York City has also been on the front lines of grassroots activism and at the forefront of breaking down stigma by creating the first government position specifically dedicated to addressing the epidemic. Additionally, New York City is one of the largest hubs of faith spaces in the country, providing for a rich analysis of the Black church's response to the community's epidemic rates of infection on a local level. The HIV/AIDS epidemic in New York allowed me to explore the intersections and collisions of national, local, and community respectability politics that impacted the Black experience. I began this work by providing historical context for how respectability politics have been historically weaponized by the state to continually construct and redefine Blackness in ways that preserve the economic status of white supremacy. I accomplished this objective by examining key shifts in conceptions of racial respectability from the colonial era through the 1950s in the United States. These turning points include the initial justification of African enslavement in the American colonies as a means for converting heathens to Christians, the 1664 Maryland law that declared baptism did not necessitate manumission, the Virginia Slave Codes of 1705, the Three-Fifths Compromise of 1787, the Compromise of 1877 that effectively ended Reconstruction, and the subsequent institutionalization of racial disparities during the Jim Crow era. By examining these key moments, I explored how the medicalization of Blackness was continuously used to substantiate shifts in respectability through clinical declarations of racial difference and inferiority prior to the Civil Rights Movement. These clinical and scientific declarations of racial difference legitimize respectability politics, thereby solidifying its influence on constructions of Blackness in America. Often the Black church, in its diversity of expressions, found itself at the helm of navigating respectability politics on behalf of the African American community during these shifts, either through its own deployment for racial uplift or as resistance to oppressive forces. Also, the importance of religion to Black American health can be traced back to multiple spiritual beliefs of different African tribes. In order to truly examine the inner workings of respectability politics as it relates to Black health, we need a historical context of the centrality of the Black church. This work illuminates how top-down perspective respectability politics were used by elites and the state to police African American bodies and impede racial progress from the colonial era through the 1950s. Additionally, it contends that these earlier shifts in respectability laid the foundation for those of the 1960s, 70s, and 80s that left African Americans at the center of the HIV/AIDS epidemic and the current COVID-19 crisis. The manipulation of respectability politics and Black health with respect to COVID-19 is most clearly exemplified in the discussion of vaccine hesitancy. There has been much conversation about vaccine hesitancy among Black people in the United States because of the longstanding distrust between the community and medical professionals for both historical and continuous neglect and experimentation due to systemic racism. Classic examples of this legacy date back to slavery with Dr. Marion Sims experimenting gynecological procedures on enslaved Black women, the Tuskegee experiment from the 1930s, where nearly 400 Black men with syphilis were lied to and denied proper treatment for 40 years, the harvesting of the famous HeLa cells used to create the polio vaccine from Henrietta Lacks without her or her family's consent. Historical memory, however, is not the only source of this distrust. The current lived experiences of Black people with medical professionals inform the current state of relations with the Black community. Currently, Black women are 3 to 4 times more likely to die during childbirth than their white counterparts. And the mortality rates of Black babies are cut in half when the doctor of record is also Black. Pregnant Black women often find their voices, pain, and concerns ignored by medical providers. Even tennis superstar Serena Williams found her voice ignored in a near-death experience following a C-section with her daughter, Alexis Olympia. Due to a history of pulmonary embolisms, she warned a nurse of her symptoms and insisted that she needed a CT scan. The nurse initially ignored her claims, but Williams continued to advocate for herself until a doctor ran the scan and found several blood clots had settled in her lungs. Williams' story shows that notoriety, income, and Gold Star health insurance does not save Black women from implicit bias and structural racism. I argue that the warranted distrust of medical professionals in the Black community is being exploited to create a myopic narrative that suggests most Black people do not want to be vaccinated and lack understanding of what the vaccine would mean for protecting themselves and their loved ones. However, recent data from the Pew Research Center speaks to the contrary, telling us that Black adults in the US across the board have heightened concerns regarding COVID-19 compared to the rest of the population, with 94% wearing masks in public spaces. In fact, 61% of Black adults surveyed said they will get vaccinated, lagging the national average by only 8%. Nonetheless, we have seen consistent reports that vaccinations in Black and Latinx communities across the country are significantly lagging their white counterparts. While vaccine hesitancy surely accounts for a fraction of this disparity, it is also being used as a scapegoat to avoid the more pertinent and costly task of tackling socioeconomic inequalities. Pediatrician and public health advocate Dr. Rhea Boyd penned a New York Times article entitled, "Black people need better vaccine access, not better vaccine attitudes," and gave an interview where she highlighted unequal access to broadband internet, phone service, regular healthcare providers, health insurance, and resident proximate pharmacies as being at the root of low vaccination rates in Black communities. Vaccine hesitancy provides a public narrative that pathologizes Black people as responsible for being disproportionately under-vaccinated, as opposed to highlighting the systemic gaps that prevent equal access to the vaccine. Dr. Oni Blackstock, former assistant commissioner for the New York City Department of Health Bureau of HIV and physician in predominantly Black community of Harlem, stated, "Using vaccine hesitant to refer to people who have not been given the information they need to make an important decision is a horrible misnomer. All my patients today were hesitant when I brought up the COVID-19 vaccine. But after I answered their questions, they were like, I want it." White supremacy often manifests itself in healthcare through blame and erasure, by framing marginalized communities as responsible for not using resources while ignoring that they do not have access to them. Black churches are being tapped as essential resources to bridge gaps in access to COVID testing, healthcare, and vaccinations in Black communities across the United States. As I will discuss regarding the role of the Black church in HIV/AIDS, mobilization of the Black community largely centers on the response of Black church leadership. COVID and HIV/AIDS have generated vastly different responses from Black church leaders due to respectability politics around modes of transmission. COVID has become what scholar Kathy Cohen was described as a consensus issue, an issue that elicits a community-wide response because of a linked fate for the entire community, versus HIV/AIDS, which was stereotyped as a vector of sexual deviance. Black church organizations, including the National Black Church Initiative and the Conference of National Black Churches, have stepped up in a major way to engage a coordinated effort to educate the Black community about the vaccine and provide the people access to get one. NBCI, which is the National Black Church Initiative, is a coalition of over 150,000 African-American churches, is working with Latinx community partners, including the National Hispanic Medical Association, on a $150 million plan to vaccinate over 106 million Black and Latinx congregants across the country. The plan that has already secured 3,500 Black and Latinx doctors will need 2.5 million volunteers to execute and will be the largest faith-based mobilization of African-American and Latinx Protestant denominations in the country to achieve a single health goal. Reverend Anthony Evans, the president of NBCI, said he hopes to meet with the Biden administration in order to facilitate this plan. He said, "Mr. President, we helped you. It is time for you to provide the resources our community needs to help us." The Conference of National Black Churches represents 80% Black American Christians, approximately 30,000 congregants. Through a $7.5 million CDC grant, the conference will implement program REV, Reach, Educate, and Vaccinate. The program targets 20 cities that have pharmacy deserts and will create convenient vaccination locations. We see the important work of the Black church playing out in Black and Latinx communities across the country. An older Black woman at First Baptist Church in Queens, New York said she felt great about receiving the vaccine and coming to a place she knew because it felt like home. My manuscript examines the complexities of the Black church and health activism. It explores the Black church as both a victim and perpetrator of respectability politics as a tool of oppression over time, and the impact it's had on the HIV/AIDS epidemic. As the longest standing institution in the African American community, often the central space for organizing, the Black church played critically important roles in the formation of African American identity. Often criticized by HIV/AIDS advocates for their early silence on the epidemic in the African American community, the Black church was far from silent during the 1980s. However, their battle cries most certainly reflected the national political agenda of the day. The President of the United States, Ronald Reagan, was hard on drugs and silent on HIV/AIDS. In many ways, Black church advocacy reflected this language, a product of the nation's respectability politics. The negative impact of Black church leadership's silence on the epidemic is without question, as it muted the voices of the afflicted in the community through erasure. Reverend Irene Monroe stated, "We Black clergy knew that HIV/AIDS was killing African Americans before the CDC because they were coming to us first. We were visiting them at home and in the hospitals when they were sick and dying. We were the ones performing the funerals." Through an analysis of the complex relations between Black church leaders at local and national levels, I examined their stark difference in perceptions of respectability politics in the 1980s and its subsequent impact on the responses to the HIV/AIDS epidemic. In the absence of HIV/AIDS advocacy for the community from the Black church, there was a rise in grassroots activism via nonprofit organizations like Gay Men of African Descent, the National Black Leadership Commission on AIDS, and Balm and Gilead, organizations that were all formed in the late 1980s and early 1990s. Each made efforts to bridge the gap between the church and community regarding HIV/AIDS. Gay men of African descent, also referred to as GMAD, appealed to the community to see them as their brothers and sons and recognize that homophobia was yet another manifestation of white supremacy. Balm and Gilead, in particular, functioned to provide clergy with the language they needed to help those living with the illness. While the effort of grassroots organizations made strides in bringing Black church leaders into the fight against AIDS, there were still figures like Pastor Jordan, pictured here, who felt that AIDS was God's curse on homosexuality. And interestingly enough, about Pastor Jordan is there was, of course, a severe backlash to this message being posted in front of his church. But he doubled down on this when he was interviewed again about it in 2014. So clearly, you know, as much progress has been made, this is still there's still much work to be done. So this work does not seek to excuse the silence and slow response of Black church leaders to the epidemic, but it does contextualize the response within the complex respectability politics of the Black community in the 1980s. Similar to the HIV/AIDS epidemic, grassroots organizations have been a critical component in combating COVID-19 in Black and Latinx communities. Many of the same organizations who built community frameworks that provided the most marginalized of these communities with resources to combat HIV/AIDS are currently bridging the same gaps for COVID-19. The National Black Leadership Commission on Health, formerly the National Black Leadership Commission on AIDS, partnered with New York City Health and Hospitals to create test and trace programs in Black communities with zip codes reporting the highest rates of infection. Between July and November of 2020, Black Health leveraged their relationships to host over 600 events, connecting with over 100,000 New Yorkers in high-risk environments, distributing over 500,000 masks along with other resources to combat COVID-19. The president of the National Latino Commission on AIDS and founder of the Hispanic Health Network, Guillermo Chacon, has been tasked by New York Governor Cuomo to serve on the COVID-19 Vaccine Equity Task Force. Chacon is joined by 19 other leaders of nonprofit, faith-based, and community-based organizations that focus on shrinking inequities in communities of color. As Dr. Rhea Boyd discussed the misnomer of vaccine hesitancy in her interview, she also mentioned that when vaccination sites with appointments that don't require internet access are created within Black communities, the people show up. This is evidenced by the Black Doctors COVID-19 Consortium in Philadelphia that created a mobile testing and vaccination unit and allows people to come as walk-in appointments on a first-come, first-served basis. The consortium outpaced the city's average of 3,500 vaccinations a day by vaccinating 4,000 residents during the first 24-hour walk-up site. Even more remarkable, 3 out of 4 Philadelphians vaccinated at the city's first round-the-clock walk-up site were people of color, a particularly notable number in a city where 55% of people who received the vaccine at this point were white, even though they only make up 40% of residents. We can see that this model is spreading across the country, and we've seen over time in the last few months that now people can readily receive the vaccine at their local pharmacies, and this has also increased the vaccinations and particularly, even though we're seeing a slowdown overall, it has increased the vaccinations in communities that were lacking the ability to get to certain sites or to get appointments because, you know, early on, people were staying up all hours of the night trying to secure an appointment. So once people were able to go to their local Walgreens or mom and pop pharmacy, that people started to take advantage of it. So to create this idea and say that there was that people just didn't want to get vaccinated, when in many instances there were people traveling from wealthier communities to low-income communities because they wanted to get the vaccine and they had the ability and access to and time to, you know, stay up all night maybe to get that appointment, the one of the 100 appointments that became available at 12:30 in the morning. So these are the differences that we've seen over time with the development of availability of the vaccine. So the next section of my project focused on trickle-down respectability politics in HIV/AIDS in Black America, and explores how definitions of respectability were shifted by the state in the 1960s, 70s, and 80s for the maintenance of white supremacy, and how this respectability was specifically weaponized to keep the status quo following the civil rights movement. Using President Lyndon B. Johnson's administration as a starting point, I chronicle how the state's manipulation of Black respectability and subsequent criminalization of Blackness increased African American vulnerability to HIV/AIDS through Ronald Reagan's administration. The civil rights movement was ideally supposed to serve as a bridge to equity along the American color line by doing more than simply quelling the rampant violence and inhumane treatment of African Americans. However, gaping disparities in employment, education, housing, and healthcare persisted from the 1960s to the present. I argue that the socioeconomic deficiencies that persisted in spite of the civil rights movement and Black Power movement were intentional and systemically meant to leave African Americans vulnerable. The 1980s brought the twin crises of HIV/AIDS and mass incarceration to a community ripe with susceptibility. More broadly, I argue that the blatant manipulations of respectability politics by state actors, either through demonization or erasure of undesirable groups, demonstrates that white supremacy adapts to eliminate any threat to its sustenance. This section considers how respectability politics was weaponized by the state against African Americans to allow socioeconomic and health disparities to continue after the corrective legislation of the civil rights movement through the Clinton administration of the 1990s. Using New York City as the case study, I analyzed the consequences of weaponized respectability politics on African Americans at the level of local government's handling of the HIV/AIDS epidemic. Examining the response of the respective New York City mayoral administrations to the aforementioned presidential administration's approaches to the HIV/AIDS epidemic. I examined the impact of federal respectability politics on local government. Excavating the voices of people living with AIDS in New York City, like Ty Fortner, a formerly homeless sex worker who purposely sabotaged his health with HIV to qualify for New York City government-funded AIDS housing. I exemplify the impact of respectability politics on the AIDS epidemic. Ty Fortner's story is especially poignant, and this is something that I use when I talk to my students about housing, and how one of the main components that I came across in my interviews with HIV/AIDS advocates, which was a surprise to me, was that housing is seen as HIV prevention. It's one of the main components to preventing HIV. And, we don't think about how the level of desperation that comes with not having access to stable housing. And Ty Fortner, he found himself homeless at the age of 16 and ending up becoming a sex worker in order to support himself. And by the age of 20, he was HIV positive and had developed a drug problem and was doing what he needed to do to survive on the street. And once he received his HIV diagnosis, he found out about New York City's HACA program, which provides housing to those who are living with AIDS. But that meant that he had to have an AIDS diagnosis in order to qualify for it. So what he did was he sabotaged his health. He purposely didn't take his medication for months until he ended up in a nursing home with blood clots and could barely walk. And at the age of 28, he received his AIDS diagnosis and the keys to the very first apartment he'd ever owned, or that he ever had. And when asked, he said that it was worth it. So when we put people in a situation where they're willing to risk their life in order to have access to basic resources, we're creating a level of desperation that does not go with our normal way of understanding how to respond to situations. Desperate people are in spaces where, and really this comes back to this conversation and the larger conversation of poverty and its impact on health. And when we're saying that this is systemic, this is what we mean. That, having legislation that says, hey, you have to be almost at death's door to qualify for access to housing that could have maybe prevented you from being in this situation in the first place. We're dealing with a backward system. So the former associate manager and social worker for the AIDS Service Center of New York City, Kiani McCoo, stated that the access that people of color have to healthcare in New York City is amazing. The dedicated HIV/AIDS clinics where patients can get quality care for amazing from amazing experience and compassionate doctors is a great model. Is it perfect? No, but it's the best in the US. McCoo stated that that housing is the most glaring flaw in the New York City AIDS model. This sentiment is reflected most clearly in the charts on the screen that show the parallels between poverty and HIV. And if you're looking at this, you can see that you can almost lay these maps on top of one another. And I've also included here the COVID-19 map as well. And you can see that the same communities are disproportionately impacted by poverty, by HIV, and by COVID. So that there is a very clear relationship between living in poverty and having poor health outcomes. This is a charted reflection of working class communities with jobs that didn't allow them to work from home, mostly generational households, limited access to quality healthcare, heavy reliance on public transportation, underperforming schools, and housing insecurity. Presidential and federal government responses to public health emergencies in the United States of America set the tone for how well the country will bode in successfully combating it. We now know from Elite's interview that by at least February 7th, former President Trump knew that COVID-19 was airborne and described it as, that's a very tricky one. That's a very delicate one. It's also more deadly than even your most strenuous flus. But publicly in late February, he said, it's going to disappear. One day, it's like a miracle, it will disappear. By late March, then President Trump branded himself as a wartime president in the early stages of the pandemic, but then immediately followed by delegating all responsibility for COVID response to state leaders. He told New York's governor in April at the height of its state of emergency that the federal government is merely a backup to the state government. Decentralizing authority in the middle of a national crisis is unprecedented. The lack of a national strategic plan and guidance caused governors to form regional alliances to coordinate responses to COVID and plans to reopen safely. These alliances were viewed as opposition to the White House. The concepts of masks, social distancing, and vaccines were turned into political footballs instead of public health measures. Trump's refusal to comply with regular mask wearing and blasting of states who were not ready to safely reopen emboldened resistance to these measures on the ground level, putting Americans at greater risk. There is another disproportionate impact that COVID pandemic has resulted in, and that is women leaving the workforce at faster paces than men and returning slower. The HIV/AIDS epidemic in Black America also had a gender dynamic. My research uses gender to explore the intersectional impact and relationship between white supremacy and respectability politics with regard to its impact on the HIV/AIDS epidemic in the Black community from the 1980s to 2010. The demonization of gay white men and erasure of white women from the HIV/AIDS epidemic evidence that white supremacy does not distribute its privilege equally. As a historian, I'm sure most of us can really have that one particular piece of evidence or source that just really stays with you. And for me, one of those sources in this project was an article that was in Cosmo magazine, written by Robert Gould in January of 1988. And it was called Reassuring News About AIDS. A doctor tells you why you may not be at risk. So the problem with this article is that Robert Gould basically says here that as long as you are not having engaging in deviant sexual practices, you should not contract HIV/AIDS. That those who are having sex in the missionary position are safe. It's those who are engaging in other forms of sexual activity that are at risk. And this is especially nerving because, like I said, this is 1988. It's very clear at this point how HIV is transmitted. There's already been this mass mailing to every household in the United States by the Surgeon General to tell people how they can protect themselves, how this disease is transmitted. So, but when we think about this, a note from the Surgeon General versus an article in Cosmo and what people are most likely to relate to, right? This is what makes it so dangerous that he's put this article out there, and comes to find out, he's a psychiatrist. So, which is, nothing's wrong with psychiatrists, but he's not an epidemiologist. He's not a virologist. This is not his specialty, but he speaks as, I am a medical doctor in this Cosmo magazine in a time where we're not just Googling people and checking out, their reviews. So he shares this article telling these women that, as long as you're not doing anything deviant, you're safe. And when he received pushback in his questions by saying, well, don't we have documented cases of heterosexual transmission in certain African countries? And he doubles down on racial stereotypes here to further his point. And he goes, well, it's been brought to my attention that, African men take their women in a very brutal way that's tantamount to rape. So that's why they're able to have heterosexual transmission of HIV/AIDS. Which, one, he's doubling down on these racial stereotypes and criminality of Blackness. And then two, there's an erasure of white women here, basically telling them that as long as you, carry yourself in a respectable way and only have sex in this position, then you won't be at risk for HIV. And this basically sparks the women's contingent of ACT UP and the initial activism from ACT UP to advocate for women living with HIV as well. And through a juxtaposition of my interview, I personally conducted an interview with an HIV/AIDS advocate named Roussel Miller Hill, a formerly incarcerated African-American woman living with AIDS, and the life of a renowned AIDS activist and survivor, Ray Lewis Thornton. I examined the impact of internal gendered respectability politics in the Black community. These internal respectability politics put an educated, middle-class, sexually conservative Thornton as the face of Black women in the epidemic. That is the woman on the left. I hope that's the left for you all in that cover-up essence. While erasing the experiences of poor Black women and those combating addiction like Miller Hill on the right. Moreover, I contextualize the role of state and elites in shaping their experiences. This section also examines how respectability politics painted Black women as victims of duplicitous bisexual Black men to protect their respectability at the expense of their sexual autonomy. As Miller Hill takes me through her personal journey with HIV/AIDS, not only as a prisoner in New York, but also as a mother, wife, and advocate, I include the relevant policy changes and political agendas that shaped her experiences on the local and national level. This work goes beyond the orthodox depiction of Black women as bystanders in the phenomenon of mass incarceration in the African American community. It examines their experiences as subjects of the carceral state, as opposed to wives, girlfriends, and mothers of incarcerated Black men. Regarding African American masculinity, I consulted multiple archival resources, including the Gay Men of African Descent organization, along with my interview with Angelo Pinto, formerly with the Arthur Ashe Institute for Urban Health. Pinto, in conjunction with a physician from SUNY Downstate, oversaw a series of barbershop talks designed to figure out African American male perspectives on sex, sexuality, and HIV in New York City neighborhoods with high HIV prevalence rates. I explore the impact of toxic conceptions and stereotypes of African American masculinity and hypersexual and homophobic in combating the community's AIDS epidemic. When I wrote the epilogue of the dissertation version of this project, I had a sentence that read, ultimately, a cure for HIV/AIDS could be found tomorrow, and a new disease would emerge, wreaking the same havoc on the African American community because the structural racism that prevents access to necessary resources have not been addressed. Little did I know that disease was less than a year away with the onset of COVID-19, disproportionately impacting Black and Brown communities. As long as respectability politics are weaponized by politicians pandering to white conservative and Christian values while wielding stereotypes about criminality, hypersexuality, and laziness regarding racial minorities, government policies will continue to reflect bias and promote disparities along lines of housing, employment, and ultimately health. Scholar Ibram Kendi spoke to this sentiment, stating, any politician pledging to keep us safe who is drastically overfunding law and order, border security, and wars on terror, and drastically underfunding medical research, prevention, and healthcare, is a politician explicitly pledging to keep our bodies unsafe. My manuscript's current epilogue, entitled Black Lives Matter and HIV/AIDS, Where Are We Now?, examines the current state of the HIV/AIDS epidemic in the African American community, its parallels with the COVID-19 pandemic, as well as the contentious role of respectability politics from President George W. Bush's administration to Donald Trump's administration. It addresses the major pushback against intersectional forms of respectability politics during President Barack Obama's administration through massive legislative healthcare changes and the resurgence of social justice grassroots activism in the African American community, a movement triggered by the 2012 murder of Trayvon Martin. Many people think about the Black Lives Matter movement being triggered by George Floyd's murder last year, but this is a movement that has been going on for over 8 years at this point. Actually, for over 9 years at this point. Specifically, it examines how the 2010 enactment of the Affordable Care Act, also referred to as Obamacare, the largest healthcare legislation since the advent of Medicare and Medicaid in 1965, made strides to close racial and economic gaps in access to care. In addition, I analyzed how the 2016 presidential election of Donald Trump was part of a larger visceral backlash to the progressive legislative changes and social justice protests of the Obama era that threatened to shrink equity gaps for underrepresented groups. Like the criminalization of Blackness under Nixon and Reagan administrations, the Trump administration characterized Mexican immigrants as rapists and criminals, and Black Lives Matter protesters as anti-American. This work investigates how Trump and his administration use xenophobic and racially coded language to manipulate definitions of respectability to marginalize disenfranchised groups, specifically for the maintenance of white supremacy, and the impact these actions have had on the HIV/AIDS epidemic and, more recently, the COVID-19 pandemic. The Trump campaign capitalized on the distressed white working class vowing to make America great again by promising to undo Obama-era advancements in healthcare, criminal justice, housing, and tax reform. The very things the CDC has censored as being critical to eliminating these disparities in healthcare. And the success of Trump's campaign provides a contemporary example for the paradox of respectability. When white supremacy is threatened, the definition of what is respectable will adjust to protect it. And we've seen this most clearly evidenced in what happened at this United States Capitol building on January 6th. And we've seen kind of like a whitewashing in more recent time of saying, oh, it wasn't that bad. And it was an insurrection. You know, people stormed the Capitol building. But the same language is used to discuss Black Lives Matter protesters from last summer, which is not the same as committing treason. So, we see how these definitions change to adjust to the group that's being targeted. So consistent with the rest of this work, the epilogue considers New York as its case study for analyzing the response of local government. Locally, New York Governor Cuomo instituted a 3-point plan called End AIDS 2020. The goal of this initiative was to reduce HIV/AIDS prevalence to a maximum of 750 new infections per year, compared to an estimated 3,000. And not only explore the feasibility of the End AIDS 2020 campaign and its scope in addressing root causes, but also the ability to maintain progressive policy at the local level when the federal government is moving in the opposite direction regarding the epidemic. We are still waiting for as we can see in these charts, that things are moving in the right direction. At least they were moving in the right direction up until 2020. We're still waiting for the 2020 numbers to be provided to see if the goals were met, but I am not sure that 2020's numbers will be very accurate in any case, because so many people are afraid to go outside to go to a doctor for general physicals and checkups that I'm not sure that those numbers will be completely on point. So with a 38% reduction in new yearly cases since the beginning of the campaign in 2014, Governor Cuomo believes New York City has bent the curve on HIV in New York State. This is quite remarkable and supportive of social worker McCrew's earlier point that New York does a great job of connecting those living with HIV to care. And to kind of circle back to that, we have seen there have been adjustments made to the legislation about HACA, which is the policy that Ty Fortner was referring to in terms of qualifying for access to housing, so that you don't necessarily have to, you still have to have a certain T cell count, but you don't necessarily have to have AIDS in order to qualify for access to housing now. So my work used HIV/AIDS to exemplify the effects of a failed realization of the American racial equality promised by the legislative successes of the civil rights movement of the 1960s. Since 2013, the American people have lived in a time that mirrors the racial dynamics of the late 1960s in the United States. In urban cities, the rate of unemployment for African Americans is at least double that of their white counterparts. The schools in African American communities overwhelmingly perform poorer than that of their white counterparts, and access to affordable housing is increasingly limited. The COVID-19 pandemic has only exacerbated these problems. Incidents of police brutality against African Americans are splashing across newspapers and television screens at almost a monthly rate. While there are promising campaigns to end the AIDS epidemic, African Americans still account for nearly half of all new infections and currently lead mortality rates in the COVID-19 pandemic in the United States. The question remains, where are we now? The answer to this point is inconclusive, as it appears that we are in the midst of a new civil rights movement featuring the Me Too movement, gay rights advocacy, and Black Lives Matter. White supremacy has been successful to this point because of its umbrella effect. While it only protects and serves straight, wealthy, cisgendered white men the most, it offers some protections to white people and wealthy racial minorities that do not fit this mold. This was exemplified in my gender section, where gay white men who had been all but forgotten by the government in the early days of the HIV/AIDS epidemic went on to exclude advocates of color as the epidemic browned, and they secured their own funding. The real question becomes, have we reached a point where each marginalized group across lines of race, class, and gender can appreciate that in order for true equality to be achieved in any of these areas, it must be achieved in all of them? In order to prevent the next epidemic from presenting in the same manner as COVID-19 has evidence, structures that protect white supremacy must be dismantled. Thank you.
Thank you, Aisha. I'm going to try to go on to gallery view now. Can you, there we are. Okay. That was very, very powerful. I have to take a breath before I say anything. It raises so many questions, and it raises so many issues that arise not simply in our thinking about the United States, but about how what Aisha says resonates elsewhere. So I'm just going to open up the floor. We have two comments so far. One by Distria that says, "Thank you for a wonderful, thought-provoking talk." Well, so I suspect that Distria agrees with me. And one from Susie Wormbrand saying, "Thank you for this interesting talk and all the important research." So any questions, comments, reflections? Are there any hands up? Am I missing any hands up? Well, all right, I'll start. And I'm going to ask a question that can't be avoided, but is probably unfair given that your research is on the United States and on New York. So I'm asking you not to draw on your expertise, but just on your thoughts, okay? Are we talking, or are you talking about something that is, if not uniquely an issue of the United States, a particular issue of the United States? Are many of the observations you make, do you imagine, relevant to many other parts of the world?
I think that there is definitely a connection to the global impact of just talking about HIV/AIDS generally. And we look at sub-Saharan African countries who have experienced disproportionate impacts of HIV/AIDS, and also the way that respectability is used to kind of brand these countries a particular way. And we're also looking at lack of access to, in terms of equity to healthcare resources. So I think that on a grander stage, that we're seeing these ideas play out on a broader stage as well. I don't think that the United States is an example of how this is happening in other spaces as well. And it's not, and there's a reason why, even in the way I redefine respectability politics, that I don't root it in race, because it's a power thing, right? It's about whether the group that has the power is able to define the parameters for those without it. So, even if we're in a space where everyone is white, but there's a group that's poor, if you describe those people as being lazy and not wanting to work, or not wanting to go to school, or not being smart, and they don't want to go to the doctor, then you can say that those people are responsible for poor health outcomes, rather than saying, hey, we don't give these people enough resources so they can take care of themselves properly. So I definitely think that this is something that we see playing out across the globe.
Okay, Dorodista, you made a comment that I think, if you wouldn't mind just repeating it for everybody.
Yeah, hi. Thank you, Aisha. It was a brilliant talk, as I said.
Thank you so much.
Yeah, so as I said, so we had a program on TV last month in the UK, which was a big eye opener here. I would say, that showed in regards to COVID, a lot of the things that you said in your talk showed for America, and the impact this had on the BAME community. And one of the things that came out when the presenter was talking with a lot of the researchers who are doing research on this currently as to why it's affecting this community more so, is that their idea was that it's not racist in a sense, for a lack of a better term to use in regards to COVID, by targeting these people, but it is more in a sense focusing on, sadly, on the fact of their socioeconomic background, so a huge majority of them being in poverty, or not earning as much as other white folk and things like that. So what happens is, especially if you've got a whole crowd of let's say 3 or 4 or 5 families living in one house, they don't have the same opportunities to self-isolate or quarantine somewhere else as, say, a white family that only has 3 or 4 people in the house. And I think those were very serious points that I think even before lockdowns were not even thought about, how this would spread much more quickly, and lockdown would in a sense make it worse, especially to those that had to go to work in order to earn an income.
I think that you bring up a really good point here, because one of the things that I think when when we talk about racism, because it's such a charged word, I mean, rightfully so, right? But it's, people think about, kind of from an American context, they're thinking like the Ku Klux Klan, they're thinking tiki torches, they're thinking, burning crosses. But when we're talking about how things become systemic, right? The idea that there are communities that are just more impoverished. And because they're more impoverished, they don't have the same, the school systems there are poorer, the education outcomes are poorer, which means the employment opportunities are going to be more service-based or lower income. And there's going to be a need for them to be multiple generational households. So this is how something translates from having to be an in-your-face, like, racist thing happening to it's systemic now. It doesn't need people to be racist on an individual level, because it has become so much part of the system that it protects itself. because it's hard to get people out of those spaces when they live in them. I did a community needs assessment for a underserved community in Brooklyn, and there's a public housing daycare center that I went to, and one of the things that this project for me is kind of illuminated what my next projects will be, is that looking at how public housing was supposed to be this bridge to the middle class, and it has instead, at least in the United States, become a space for cyclical poverty. And I've spoke to people where there's 4 generations that have gone to this daycare. So what has happened that people are stuck in this poverty, in this public housing, and they never get to the next space.
That's really interesting. Actually, you're saying that, and what is fascinating with what you're saying, and also what I've heard here was that the people that were also affected were also those that were working in the medical profession here in the same communities, which everyone was thinking, because they're doctors, surely they must have been protected and therefore not as much affected, even though they were from the same community. And in actual fact, it was the complete opposite, which I think is shocking to a lot of people here, considering how they view the NHS, thinking that because it's free, that automatically means that you've got medical health care and therefore you have certain more protections compared to other countries. And I think this is the first time where it's come out to say that that's not, in a sense, the solution. That's more like a band-aid that you put over the wound. Right. And it still affects these people in a huge amount, and especially, for example, for those that had to work 3 or 4 double shifts compared to everyone else to try and earn extra, and which still apparently led to nowhere, even in the medical profession side. So it's quite interesting to see how they've kind of been a lot of various links this past year, in all the different countries, and thank you for actually bringing that out more so in America.
Okay. Anyone else? Any other hands up? Comments? Giovanni.
Yes, thank you, Aisha. That was really, really thought-provoking, really powerful. Thank you very much for bringing so many new things also for me up. I had a question about respectability politics. First, I mean, I had a comment, and I thought about another parallel with somewhere else in the world is the division between the good and the bad migrants. The weaponization of respectability politics, I think, plays out also when states or local authorities say, no, we're not against migrants because there are good migrants, that those who work or integrate, but then there are the bad ones. And I think that also plays, as a bridge with what you were saying. I'm thinking about Europe, especially immigration in Europe and discourse immigration in Europe. But I wanted to ask you one thing, just to put it very, very bluntly and shortly. Do you think the problem is the respectability politics or its weaponization? And if the problem is respectability politics in itself, then is there a way to, how can we tackle it critically? How can we build a critique of it? And from which standpoint, maybe?
Ooh, you have the trick question for me. So the thing about respectability politics, right, is it's a double-edged sword, is the way I've kind of seen it. Is because respectability politics has, when you're looking at Black American history, it's been a tool that has been employed for advancement. When you think about someone like Booker T. Washington, who kind of appealed to his white counterparts by saying, Black people, we don't need to start at the top. We'll start at the bottom and we'll earn our way to the top. But he felt like if this is what needs to be said in order for me to get access to funding, to start schools, to start these historically Black colleges, then that's what I need to do. But the problem with respectability politics is that, and while it will always be a double-edged sword, is that the people who are the minority are not the ones defining what's respectable. It's the majority power that's deciding what's respectable. And they can also change that definition whenever it suits them. If they're like, it is not respectable for for women to wear pants. They're like, that's not respectable. You can't do that. And then if somehow the majority decides that, it is respectable for women to wear pants, then it's like women can wear pants. And now that's the new rule. So you're moving to try and keep up with whatever this majority group is saying is respectable. So I think that and really when we've seen respectability as a weapon of oppression, it's basically those who are operating from the bottom, the marginalized groups, figuring out ways how to weaponize respectability against those who are trying to control them. So I don't know that there's a winning standpoint of respectability politics. It's just that until we can eliminate it, I feel that people from marginalized groups are always going to try and find a way to use it to their advantage, which they should.
Okay.
I hope that did I address the question? If you need more clarification, let me know.
No, absolutely. I totally agree with your last point about mobilizing respectability politics for people's own minorities' own advancement.
Yeah, I actually think that up to now, I really haven't seen a lot that has discussed the idea that respectability politics is weaponized. Typically, it's discussed, at least in African American scholarship, as a weapon against oppression. But it's what people don't realize. Respectability in itself is a weapon of oppression. So it's a circle here that we're in.
Okay. Anyone else? Any other hands up? Well, Aishah, I have many questions, but I can ask you these questions between the two of us at some point. Even when you end up in Providence, I still know how to get in touch with you.
You sure can.
Anyway, if there are no more questions, John, you texted they can continue this on something after 3 o'clock, but I forget what it was.
Yeah, I mean, we can continue now until 3 o'clock if there's more.
Yeah.
And we wouldn't mind hearing one of your questions, Gary, if you'd like. But then the discussion can and should continue in the form of people's responses or questions or follow-up in the discussion space over there. That would be great. But we can go a little bit more if there's any questions right now.
All right. Well, I'm never at a loss for questions. If you want me to ask another question. Oh yeah, Polly has a question. No.
Yes. So I, like Gary, there are so many things that I could ask, and what I am going to, and I'm just going to ask one thing, and it's going to sound very simplistic because I'm not asking as a historian or a sociologist. It's so self-evident to me that poverty itself is violence. And it seems that, to me, it seems from what you said that the respectability politics is a way of somehow obscuring the fact that poverty itself is violence and that it is not a consequence of behaviors, that it is in fact a result of this oppression, as you say. Also so clear, but it doesn't seem to be, there seems to be some sort of short circuit, and it doesn't seem to be possible to see or to say that poverty itself is violence. Does it just look this way to me because at the moment I'm not in the US, and it's so troubling, it's so disturbing that something that is so obvious seems to be.
I think that you are completely on point, actually. That the idea is that there is there is an obscurity that's happening here, and it's intentional, right? Because if we're saying that Black and brown populations are disproportionately impoverished, then by saying we need to correct poverty, we're talking about equity, and that becomes a different conversation immediately. People don't want to hear, because it's been, which is why I keep coming back to this idea of white supremacy, right? Because when you start talking about equity, you start talking about a threat to that idea. And that's when you're going to immediately start receiving pushback. Because what you're saying is that at its basic core, if we address this poverty issue, we will address these health disparities. But once you start talking about addressing poverty, you're talking about addressing housing disparities, education disparities, and employment disparities, which means that you're eliminating white supremacy. And there's always going to be a pushback when that's the conversation.
Yeah. And so it's not at all far-fetched to call this genocide. I can imagine that particularly the people who want to hide from themselves the fact that this is intentional and that this is a policy would find it completely unpalatable to think about this as a genocidal practice or policy,
and that's where the respectability element comes in, right? So we say, oh, this is about people who are just having unprotected sex. This is about people who just aren't being, they're being sexually deviant. They're doing something wrong as individuals. And this is where there's kind of like the convergence of these issues coming together.
Okay.
thank you.
Anna Sidova.
Hello, thank you very much for your speech. I wanted to ask you about psychological problems as well. So, for example, we know that, about poverty and Black society or other color society and white society. So, for example, we know that psychological problems now, even in Russia, they are rising now. So we work with them and stuff. So, why is the person poor? Is it a psychological problem? So I want to ask you about Black communities. So is there this problem? Is this problem exist? I mean, psychological medicine as well, psychological help.
So
is there any difference
between, so are there like mental health problems within the Black community that are also not being addressed that are impacting poverty? Is that the question?
Wait, sorry. Just I want to ask you, is if the help exists, if there is any difference in help with psychological problems or health problems is there any difference between white community and Black community?
Well, I definitely think in terms of access to healthcare resources generally, there are gaps in the Black community and the Latinx communities versus their white counterparts, because there are pharmacy deserts in the Black and brown communities. There are healthcare deserts in Black and brown communities. Not all of them, but they are disproportionately in those spaces and in impoverished communities generally. So if people can't get access to proper healthcare, proper general healthcare, I would also say that there's not access to proper equal access to mental health resources as well. But in terms of not being able to get access to well-paying, being underemployed, I don't think that that's necessarily correlated to psychological or mental health issues as much as it is correlated to not having access to the same educational resources, the same housing resources. Some of these kids are dealing, if you're coming from, you have kids that are living in shelters or with their parents, they have different worries than a kid who just has to go home and eat their fruit snacks and do their homework. There's a different level of concern that comes with being a child in a home that is impoverished versus one that is middle class or above.
Okay. Any other hands raised? Do I see any other hands? Okay. Well, it's just about out of time, but I'm just going to raise one thing that I don't expect you to answer. And that is, as I listen to you, the same question occurred to me on Tuesday when Giovanni was speaking. It really strikes me that these are issues that in one way or another are relevant globally, really relevant globally. The notion of respectability politics is something I have to get my head around. I haven't thought about it very much, but the growth in global inequality is not simply within a nation, it's happening everywhere in the world. The growth in homelessness, the decline in access to resources. I mean, one of the, a lot of people on this Zoom, whether you're living in the Russian Federation or the Russian Federation plays a major role in your mental world, like many of us. It's distressing and alarming to see the small number of the small percentage of people who are vaccinated there. Even though Sputnik 5 is said to be relatively available. And you read online about various explanations, but I wonder to what extent the kind of systemic analysis that you've given us today, and with a sort of long history, might be relevant there as well as in many other countries. The other thought that occurs to me, and here this is the historian in me speaking, one of the great consequences, perhaps the largest consequence of the end of the Cold War and the collapse of two systems confronting each other, is that there is nothing challenging the power of capital in an international way, the way that there was before. This is not a political comment of any sort whatsoever, but the real winners of the Cold War are capital, and that's true everywhere. And that seems to me to play directly into many of the points that you're trying to make today. Aishah, this is a really thought-provoking talk you gave today. It's 3 o'clock. I'm going to get off, but I'm just going to sit in my chair and think about some of the things you said. So thank you.
So much. And thank you to everyone for sharing your time with me today.
Thank you so much. And if Aishah, if you can, willing to share your slides and perhaps your text, some of your text that you read today with us, we can post it there. People can use it as a reference for some reactions.
Is that doable?
I have a version that I'll send over to you guys.
Whatever version you think is best, that would be awesome. Thank you so much.
Okay.
Thank you again.
Thank you all.